Cholangiocarcinoma. The anatomical classification is based on its location by the CT scan. You have peripheral, perihilar, and distal. So the proximal one is also called the perihilar one, and the peripheral one is also called intrahepatic. Intrahepatic is in 10 to 20%. The most common one is the perihilar, which is 50 to 60%, and the distal one, which is near the pancreas, is 20 to 30%. The peripheral one is seen as an intrahepatic mass. There is no underlying cirrhosis, unlike in an HCC. The treatment is a hepatectomy. While a perihilar one, the treatment is a lobar hepatectomy or a resection. And the distal one, 10 to 15% of peripancreatic tumors constitute this one, and the treatment is a Whipple surgery. Morphological classification is based on the gross specimen. So you have mass forming in 20%, periductal infiltrating in 75 to 78%, and intraductal in 2%. Intrahepatic cholangiocarcinoma. The CT scan shows a mass and a rim enhancement in the arterial phase. There will be a white area around the mass. The filling is in the delayed phase due to sclerosing nature, and there is peripheral washout in the delayed phase. So you see white. Periductal infiltrating. On the CT scan, we see white enhancing, which starts at the hilum and extends along the biliary radicals. Intraductal is rare, and you see intraluminal polypoidal mass, and there is a distension of the CBD because of this. The Bismuth-Corlett classification is based on the longitudinal extent of the tumor. So we see it on an MRCP, and we first have to identify the various segments. We identify the CBD, the cystic duct, the common hepatic duct, right and left hepatic ducts. Then the first confluence is between the common hepatic duct and the right and left hepatic ducts. Second confluence is on the left side. It is segment 2 and 3. On the right side, it is anterior sectoral duct and posterior sectoral duct. The primary confluence is where the RHD and LHD join. Secondary confluence is where the ASD and PSD join, and the segment 2 and 3 join on the left side. So it's types 1, 2, 3, and 4, where 3 is further divided into A and B. So A is in 2.5%. The primary confluence is free. In 2, it's in 10%, and the primary confluence is involved. 3A, the right secondary confluence is involved. 3B, the left secondary confluence is involved, that is in 32%. And in 4, that is in 28%, both the secondary confluences are involved. The role of imaging to diagnose and characterize, it's by CT or MRI. Extrahepatic cholangiocarcinoma versus benign biliary stricture, the best tool would be a multiphasic MRI. For the treatment plan, you first determine the level of obstruction by an MRCP, and you do the Bismuth-Corlett classification. You see whether there is any nodal or vascular invasion, adjacent organ involvement, lobar atrophy. Metastasis can be done. Metastasis can be ruled out by a PET CT. MDCT coupled with an MRCP would be the best modality, because MDCT would be for local invasion and it's good for the surgeon to see. MRCP is for the Bismuth classification and to differentiate benign from malignant. The criteria for unresectability are: 1. Invasion of the main hepatic artery or the portal vein. 2. Metastasis. 3. Bilateral secondary confluence involvement, that is a type 4. And atrophy of one lobe with a contralateral secondary confluence involvement. All cases don't need a tissue diagnosis. You don't need a biopsy, especially if it is operable. Tissue diagnosis is done by EUS-guided FNB, or you can do a spyglass cholangioscopy and biopsy for FV classification, where F is form factor It's given grading 1 to 4 and vascular factor 1 to 3. Pre-op drainage of a hilar cholangiocarcinoma. This is done for cholangitis, if the total bilirubin is more than 15, if you're planning a hepatectomy, if you're planning neoadjuvant chemotherapy. You don't do multiple stents from below. Instead, what you do is a PTBD. So pre-op PTBD, you do it peripherally and you use only plastic stents, not metal stents. It optimizes the patient pre-operatively and it allows assessment of the intraductal extent. And it increases the resectability rate. But the complications would be sepsis and tract implant with tumor cells. Risks of PTBD. Procedure related are less than 48 hours. You can get cholangitis, bleeding, pancreatitis, and pneumothorax. Drainage related is more than 48 hours. It can get occluded, it can get displaced. There can be a leak and there can be bleeding or cholangitis. Catheter related, in 10 to 13 months of surgery, catheter can get seeded with tumor cells. Staging, which is TNM classification for intrahepatic cholangiocarcinoma. T is X to T4. Let's go to the N and M first. NX cannot be assessed. N0, no evidence of nodes. N1, regional nodes 1 to 3. And N2 would be more than or equal to 4 nodes. M0 is no Mets and M1 is Mets. Now what about T's? TX can't be assessed. T0, no evidence of primary tumor. TIS is in situ tumor. T1 is solitary and there is no vascular invasion. T1A is less than 5 centimeters. T1B is more than 5 centimeters. This is intrahepatic cholangiocarcinoma. T2, it's solitary and there is vascular invasion. T3, it invades the visceral peritoneum also, and T4, it invades extrahepatic structures. Now, the T staging for perihilar cholangiocarcinoma. T2, it goes beyond the bile duct into the hepatic parenchyma. T3 would be involvement of unilateral branch of the portal vein or hepatic artery. But T4 would be involvement of the main portal vein and hepatic artery. So you see how differently the T staging is for intrahepatic and perihilar. What about distal cholangiocarcinoma? It all depends on the amount of invasion of the duct wall. So T1 is less than 5 millimeter invasion of duct wall, T2 is 5 to 12 millimeters, and T3 is more than 12 millimeters, and T4, it involves the vessels, that is celiac or SMA. The locoregional treatment you can do for intrahepatic disease would be RFA, transarterial chemoembolization, which can be done with irinotecan or with GMOX. You can do a transarterial radioembolization with yttrium-90 in unresectable tumors where the median survival is more than 15 months. And radiotherapy can be done, hepatic artery infusion with chemotherapy. Systemic chemotherapy we give for unresectable, that is for palliation, we give GEM-CIS combinations the first line, FOLFOX is the second line. Treatment of perihilar cholangiocarcinoma, the treatment of choice is first surgery. We aim for a free margin of more than 5 centimeters. We can do a lobar hepatectomy or a bile duct resection plus regional lymph node dissection plus a Roux-en-Y hepatojejunectomy, because at the end of the day you have to connect it to the jejunum. 5-year survival is 11 to 67%. The treatment of distal cholangiocarcinoma is a Whipple surgery. The survival is 27 to 37%. Ideal candidates for liver transplant are perihilar tumor, less than 3 centimeters, absence of metastasis, non-resectability. Adjuvant chemotherapy we give is GMOX, that's the Accord 18 trial, and capicetabine in the BILCAP trial.